checked again. Will be checked again by the nurse in the consultation room. And she'll ask one or two of these other questions related to their history and family history and so on. If the blood glucose is raised or the blood pressure is raised and have two separate tests to show that, then they'll be start the process of educating them on their lifestyle, on their help to reduce their unhealthy eating, increase activity, stop smoking, things like that, as in the WHO guidance. And they're supported to do that with counselling by one of the staff as well as the nurse. So there's an auxiliary health worker who's helping with this two-way communication with the patient and with a family member. And then, as needed, they'll get the essential drugs added as well. And so that's, can I go to the next slide, please? That's the package of care, which includes both the desk guide and training modules, which use simple, clear language as well, explaining what to do, and case study role plays and exercises to build the skills to communicate between the nurse, as in this picture, and the patient. So you can see Akan in the bottom picture there with our colleague Obi, with one of the nurses in the health center. And you see in the bottom picture, you can see the tablet, which has been used for doing e-health. In other words, training and guidelines provided through the tablet or their computer or their smartphone. And in the top left, you'll see a picture of me just going through one of the treatment cards in orange with one of the nurses, two of the nurses, to discuss with them how they've managed a case based on what they recorded on the treatment card. So these treatment cards and the guidelines and tools training modules are all new things introduced through this development process, adapting with the Ministry of Health in these countries. And we piloted in Sierra Leone to do this in the conventional way, in other words, through hiring a venue and doing classroom training, in-service training, as is the usual thing. And it worked well, it's fine. There are weaknesses in the health system and health services in health centers, which are general, but the actual training went fine. With Nigeria, we particularly with this project tested a way of doing this online, e-health. Particularly, they were given logins to be able to view training on video, on screen, at their own pace, in the way that the nurse is looking at it in the bottom picture. And they like this, as you'll hear from Akan soon. And we did this in 20 health centers, and they recorded on those treatment cards you can see in orange that I was looking at. And next slide, please. Yeah, so, this package, frankly, was implemented in a systematic way, in the way we have done in all the countries, elsewhere, Pakistan, etc. In Pakistan, we've already got to 750,000 patients in the whole of the Punjab, Pakistan, have been identified and treated through this kind of NCD package. So that process is at an earlier stage in Sierra Leone and Nigeria. And we've done the evaluation, and we're now ready to report on that to you. What's happened with the 9 modules which were done online, pre-post test results. And they had as well supervision from the WhatsApp groups, and they had twice weekly calls and meetings. So in other words, it was done in a way that should be replicable and could be done in other places by the Ministry of Health and scale it up. And indeed, we're hoping that a particular organization which is supporting 1,000 primary healthcare centers in Nigeria is interested to scale this up alongside their HIV antiretroviral treatment care. So looking for opportunities for the next stage of scale up in both countries. And with that, I'd like to hand over to my colleague Akan to give you some of the results.
Thank you very much, John. So on to the results from this project. So we went into the 20 health facilities, and over a period of about 12 months, we rolled out this package of care, and it was delivered by the nurses right at the front line. And we thought it was quite effective. And we're using one of the NCDs as a case study, and this is hypertension. But before that, I'll just, on the table on the left-hand side, you can see the age of the patients that were taken care of was around about the mean of 52 years of age, so with a range of 36 to 66. And as John mentioned earlier, hypertension was right on top of that list. It comprised of 76% of the clients that were taken care of, and this was followed by diabetes and things like NCDs like depression, sickle cell, and epilepsy were sort of uncommon, but we dealt with, within the period of time, 564 patients who were seen at least 3 times in these health facilities. And the table at the bottom just shows that when we monitored their blood pressure at the initial visit, we brought them back 3 times and looked at their systolic and diastolic blood pressures, and we saw that there were significant improvements in both their diastolic and systolic blood pressure, with a mean difference of 23 for the systolic blood pressure when they were followed up over a period of 3 months, and 12 for the diastolic blood pressure, and these were significant. So we saw men and women, and generally speaking, they were sort of equal. That's men and women, around about 50%, except for some NCDs, such as epilepsy, where we seem to see more men, and the same applied to sickle cell anemia. And more women were seen with depression, and slightly more women had diabetes among this cohort. But by and large, there were no significant differences between both genders. Next slide, please. So we also tried to get to the root of some of these issues in the health system by conducting 4 focus group meetings, and this involved 21 females and 2 male nurses, conducted over a period of 2 months. And we were specifically looking at their uptake or appreciation of the mHealth approach that we use to this, because as John mentioned earlier, we were trying to pilot this mHealth approach in a very fragile health system. So we looked at the appreciation of the mHealth approach and also looked at their appreciation or their views on the use of this package of care. And we got very positive results, as you can see from the quotes that we got from the qualitative study. The mHealth training was seen as being a very valuable experience. Although we put out electronic tablets in the health facilities, these health workers were able to actually access the same training package on their Android phones, and they could do that at their convenience. We found, from the focus groups, that it made them feel very confident, and they learned quite a lot, and they were able to sort of take care of their clients with non-communicable diseases. It's important to bear in mind that these health workers were more attuned to dealing with maternal and child health issues. So actually taking on board non-communicable diseases services was something very novel to them. They also reported that they had multiple benefits of the online training. They felt, that they could go back to the material at any point in time and read it and understand it at their own pace. And as John mentioned earlier, we had support networks for them. We had the WhatsApp group where we would dip in and out to see what questions they had or problems, and we were providing support for them. We're ringing the facilities twice a week, and there were also quarterly supervision visits. So in addition to that, there was a positive impact at facility level. They reported that they were now able to monitor patients' blood pressures and check their blood glucoses. And we had facilitated this by actually handing out some of these devices to them, like sphygmomanometers and blood glucose monitoring kits and strips. They also reported that they had improved relationships with the communities. This was something quite novel in that setting. And they were sort of stepping out of their comfort zones. They were more used to like maternal and child health issues, but they were now, with this training, able to provide NCD care. This did not come without challenges. And they reported that the NCDs actually increased their workload because they now were seeing more wider spectrum of patients, and they had to monitor them in a way that was sort of novel to them, but was quite simple in the sense that they were putting them onto paper charts and then uploading them onto the electronic capture system that we had put in place. Next slide, please. So the next steps for Sierra Leone and Nigeria, we believe that the supportive supervision will continue. As I mentioned, we've got, the bi-weekly telephone calls, the WhatsApp groups, and we've plans in place to disseminate what we found from this research, and we're going to scale it. We are hopefully going to scale it up to the Nigerian states. We are currently in engagement with the NCD division of the Federal Ministry of Health, Nigeria, who had actually run an face-to-face training earlier on that was supported by the WHO, JIPEGO, and the World Diabetes Federation. So in a way, this is sort of trying to compare what we've done by sort of remote supervision to the face-to-face training, which is quite expensive. And you can see in the picture there, this is just the focus, a picture of the focus group discussion. You can see Emmanuel there and Obi and a representative of the Non-Communicable Disease Division of the Federal Ministry of Health, Chiamaka, on a supportive supervision visit. And right at the bottom, you can see observation of health workers actually utilizing the yellow NCD cards. So we believe that, once we're able to report all these findings to the Ministry of Health, that this would be taken on board and scaled up across not only Nigeria, but potentially Sierra Leone and the other districts in Sierra Leone. We are also working on a BMJ open paper, and there have been interactions with WHO Geneva and Afro NCD divisions just to share some of these findings. So we believe that mHealth is quite effective and is feasible because we didn't have to pay people, per DMs and get them into groups to provide this training. So potentially this is scalable and replicable within a very fragile health system. So in Sierra Leone, the training that was provided is still available, and some of the districts are able to now access that package on their training sites. Same with Nigeria, and there's potential within Nigeria to scale up to 1,000 facilities that are owned by the Family Health International group within Nigeria. So I think that's the last slide. So my sincere appreciation goes to Professor John Walley, who's my mentor, for being phenomenal, and he came out to Nigeria. I think that's his second trip now, and he had a wonderful time. It was really wonderful having him there. And also the NCD division of the Federal Ministry of Health. Chiamaka Omoleye was also really wonderful. We had lots of support with the data from Stella Arakleyan from QMU, and I can't forget my colleagues, Dr. Emmanuel Efa and Obi, for all the wonderful work they've done. They've been the boots on the ground, and I think I'll leave it here, and I'm happy to take questions. Thank you.
Great. Thank you very much, John and Akan, for that very inspiring presentation of really trying to make systemic change in a difficult context and thinking about how to embed and sustain it. And there will be questions about that on the panel. But as there are no clarification questions at this point, I think we're going to move straight to the second presentation, and then we'll come back to some of the broader issues in the discussion. So the second presentation is being made by Dr. Saleh Shadi, who's the founding director of the Global Health Institute at AUB and Professor of Health Systems and Financing. His areas of expertise are in healthcare systems and financing and evaluations of innovative healthcare interventions with a focus on fragile settings. And he's going to be looking at patient experiences accessing NCD care in Lebanon. So thank you very much, and over to you, Dr. Shadi.
Thank you, Sophie. And this is my second session today, so it's
you're working hard.
it's a RUHF day for me, which is always a pleasure. So I am presenting on behalf of the working group in NCD and mental health in Lebanon. And when I say in Lebanon, that comprises a big group that includes colleagues from both Lebanon and QMU, including Aya Nubani, Dina Mahiddin, Karen Dekau, Stella, and Alistair, Sophie, and others who work together on this project. And today we will be discussing the experience of diabetics and hypertensive patients in accessing care in two fragile settings in Lebanon. And now in my talk, we will explain a little bit what we mean by fragile settings. Next slide, please. So in terms of a little bit of overview, just to set the stage, the burden of NCD is quite large in Lebanon, with 91% of all deaths attributed to NCD, specifically cardiovascular diseases, constitutes a big portion of this. Lebanon, as you know, was an upper middle income country. So with the result of the latest economic crisis, we're probably slipping into a lower middle income, or perhaps a lower income country in the Middle East. The total population is 5 to 6 million, and the number of registered Syrian refugees is 1 million, but the actual figures are more than that. Some place it at 1 in 4. And again, we also have Palestinian refugees who have been in Lebanon for decades. Healthcare in Lebanon in general is fragmented in the sense that throughout the war, which happened between 1975 and 1990, the role of the private sector has increased in financing, but definitely in delivery of care. We do have, or Lebanon has, a high level of out-of-pocket expenditure. It has increased in the pre-crisis phase to approximately 39%, but it's still rather high. So every $10 spent on healthcare, approximately 4 are out of pockets. 60% approximately of Syrian refugees access NCD in primary healthcare centers, compared to 17% in the host community. And primary healthcare centers are a primary source of providing NCD services, because there is some form of agreements between those centers and the United Nations Refugee Council and other donors. So the refugees and more recently host communities get a subsidized rate. In 2015, there was a project by the Ministry of Public Health through funding from the World Bank to sort of strengthen primary care delivery. So this is sort of setting the stage for you in order to understand the context a little bit. Next, please. So we looked at two fragility contexts in Lebanon, and it will become obvious why we did that. Similar to to many low and middle income countries, it's very difficult, or even regions, it's very difficult to sort of group countries or regions within a country and characterize them as equally fragile. And in this example, we have two fragility contexts. The first is the that we looked at. The first is the greater Beirut area, which is the capital. So as you expect, there's a high concentration of health services in the capital of the country. There's a high level of socioeconomic inequality, you know, the hub of the capital versus the suburbs. And it does have a high number of both Syrian and Palestinian refugees. Now compare that to the second fragility context, which is the Beqa area. Beqa is closer to the Syrian borders, so there's a higher number of Syrian refugees as a percentage of the population, actually quite higher than that of the capital. It's predominantly rural. Main activity is agricultural, and also, as we would expect from many parts of the world, the farther away we move from the capital, the less is the healthcare infrastructure. So less resources, less centers, and so on and so forth. So these are the two contexts that please keep in mind. Next, please. So in our study, or this part of what we looked at in the bigger project is specifically we looked at service utilization and delivery patterns for NCD, contrasting those two fragility contexts, but also looking at issues relating to gender, refugee status, and as well as insurance. So we did that as well as experiences and satisfaction. Next, please. We used a mixed method. There was a qualitative arm for semi-structured interviews with beneficiaries, and a quantitative arm where we surveyed those beneficiaries, and we also surveyed healthcare providers. Next, please. Basically, if you look at patient characteristics by fragility, we'll see that in terms of gender and fragility setting 1 and 2, we're seeing a higher number of patients, obviously, or beneficiaries in fragility setting 2, both males and females. The females were a little bit higher, the number, than males, because remember that we went to those primary healthcare centers to survey those beneficiaries, and in most instances during the day, men would be at work, and these would be women. In fragility setting 1, so that's nationality, we're seeing more Lebanese. As we said, in the Beqa region, we have more Syrians, and we saw those more in fragility setting 2. And when we look at education, there was significant difference in both the Lebanese actually and the Syrian, irrespective of nationality, that were not educated in fragility setting 2 in Beqa compared to Beirut. And looking at alcohol, the alcohol consumption is rather low, and smoking is definitely higher, but approximately 1/3 of the beneficiaries do smoke. Next, please. Now, the main findings highlighted presented for 4 specific themes. The first theme is lifestyle counseling for NCD patients. The first finding is that women were significantly less likely to be offered lifestyle advice than men, specifically in setting 2, and that included nutrition, smoking, and exercise. And lifestyle counseling as well, patients in Beirut were given more advice than patients in Beqa, and this also speaks to the sort of perhaps level of sticking to guidelines as you go sort of more urban. And thirdly, Lebanese received significantly more advice compared to Syrians. So you will see this pattern in almost all 4 themes. The first pattern is women receiving less services overall. The second is patients in an urban setting receiving more advanced care, and Lebanese and Syrians. Now, looking into diagnostic services. For diagnostic, again, women receiving, and we're seeing between women and men, we're seeing this more in the rural setting. Huh? Women receiving or less likely to be offered specific tests compared to their male counterparts. Diagnostic tests happening more in setting 1, Beirut, and across all settings, Syrians receiving fewer services than Lebanese. Next, please. The third theme, the third sort of analysis groupings is on referral to specialists. Again, compared to women, men were more likely to be referred to cardiologists and ophthalmologists, a higher proportion in setting 1, and Lebanese more likely to be referred to endocrinologists, ophthalmologists, and Syrians. Now, these are significant results, so there are other findings that are not significant. Now, with respect to the last sort of set of findings related to satisfaction, and this is patient-reported satisfaction. Satisfaction was significantly higher among females compared to males, and this was interesting. In our explanation, the only thing we can think of is that perhaps men were sort of expecting more, and hence their satisfaction level is less. This was one of the explanations that we got to, but irrespective of that, satisfaction was higher among participants in Beirut than in Beqa', and Lebanese were more satisfied compared to Syrians. So the only sort of thing that went counterpart to what we thought is the issue of satisfaction between women and men. Next, please. So in terms of our conclusion, there are overall conclusions that definitely the issue of when we're looking at access to NCD services in fragile contexts, there is a need to look further in terms of sub-analyses depending on differences in those fragile settings. And in discussing those findings actually with colleagues in other countries, not only in the region and beyond, these are ad hoc experiences where they said that even in those host countries, depending on the characteristics of the healthcare system in that specific region, access and satisfaction differed. We found that there's an issue of differences also when it comes to nationality, Lebanese versus Syrians, host countries versus refugees, host communities versus refugees. And this is also interesting. Moving further, we'll have to understand more whether it's because Lebanese are more able to sort of navigate the system better, or this is simply an issue of national versus refugees. The gender dynamic is one that was pretty interesting, and definitely this is in line with many studies that have looked at the interaction between gender norms in communities and accessing healthcare. So basically, and as a concluding statement, that gave us an insight for us, for policymakers, for stakeholders, for UN agencies, for primary healthcare, to look more at these areas and how to improve them, just to maintain a more equitable access to NCD services within Lebanon. And I think this is a conclusion. I take it back to you, Sophie.
Thank you very much, Shadi. Very fascinating presentation, and obviously it illustrates the importance of having a very disaggregated approach to analysing services and utilisation. And I think there may be some interesting reactions also on the satisfaction element, because I think the indicator of satisfaction is, as you say, very much related to expectations, and therefore is quite a nuanced indicator to interpret in general. So thank you to the whole team for those fascinating findings. And then we're going to move on. As I said, we'll keep any main questions to the end. We'd like to pass now to Giulia, who's going to be presenting on a literature review looking at best buys, implementation, barriers and facilitators. And just to give a bit of background, Giulia's original training was as a pharmacist and public health researcher, and she's now working as a research assistant with the Research Unit on Health and Fragility. Her areas of interest include NCD governance and political economy of UHC, and she's undertaking a PhD with Queen Margaret University on that topic. So welcome, Giulia, and over to you.
Thanks so much, Sophie, and hello, everyone. It is definitely a great pleasure to be presenting today on behalf of the rest of the team. And this presentation focuses on the WHO best buys policies and the emerging evidence on the barriers and facilitators to implementation. So next slide, please. In order, a little bit of background about the WHO best buys policies. So in order to address the burden of non-communicable diseases, the World Health Organization and other actors propose a set of interventions for the adoption and implementation of these policies. In 2013, the World Health Assembly endorsed the WHO Global Action Plan for the prevention and control of NCDs. And part of this plan included updating the assessment relating to the best buys. In this update, the interventions were designated as best buys if they were cost effective. Examples of these updated best buys included increasing excise and prices on tobacco and alcohol purchases, or reducing salt through behavior change communication and mass media campaigns, or reformulating food products and front of package labeling. And also physical activities campaign, drug therapy and counseling for those who have had a heart attack or stroke. Next slide. However, a UN General Assembly meeting in 2018 found that most member states are currently actually off track from achieving NCD-related targets, and the evidence points towards stagnation of NCD policies, including best buy implementation. One of the reasons might be that countries actually face serious challenges in adopting and implementing this series of suggested interventions effectively. Therefore, identifying the barriers to implementation and the adoptions and actively addressing these might result in increased uptake and implementation of best buys. Next slide. So therefore, in order to identify these factors and given the complex nature of the interventions on the study, we decided to conduct a systematic review incorporating a complexity approach. And as such, drawing on the complexity science and realist review tools, including elaboration for program theories and causal loop diagrams. As well, we adopted also a political economy perspective. We had mainly three research questions that we focus on. The first one was, how are the best buys adoption implementations conceptualized? So we scoped the research field, and after reading the included studies, we elaborated an original program theory, which was depicted as causal loop diagram surrounding the best buy adoption and implementation. The second research question was around addressing specifically the barriers and the facilitators to the adoption and implementation of the best buys. So basically, we proceeded as per standard systematic review methods and extracted data per study and quality assessing studies as well. So we thematically analyze and narratively synthesize the findings across the literature and contrast these to the initial program theory that we developed. The third research question we focused on was understanding the context, the influence of context on the best buy adoption and implementation. And so, again, starting from our program theory and in line with the recommendations for reviews, we adopting a complexity perspective perspective, we conducted the analysis and synthesis by taking into account the contextual features of the countries and the settings. And we then provided an overview of how this can influence the specific barriers on facilitators. Next. Here a little bit more about the methods. As I said, we conducted a standard systematic review. So we searched in several databases, and after the initial search, where we addressed more than 9,000 papers, and based on our eligibility criteria, 146 papers were included after the full text screening. And we divided the included papers based on policies, and specifically on diet, physical activity, alcohol, tobacco, health system policies, and also NCDs if the studies were focusing on more than one best buys, or we're talking about NCDs in general. And the more represented studies were on diet. Next slide. So here we want to show a little bit about the initial program theory that we developed. And this diagram it does not distinguish between the varied types of best buys or the different types of policies, but instead depicts the central processes involved in the best buy adoption and implementations, and in particular about the abilities required by the various stakeholders involved in such processes to bring successful impacts on NCDs. And in particular, we addressed the central dynamic, which is defined by the bold lines. And this illustrates the three core abilities that we believe various stakeholders should have in order to engage in this process. Next. So here, this is just the central dynamic that I just mentioned. And basically we can see that we focus on, we highlighted these three factors, these three variables that have a central role, such as the ability of the stakeholders to define and pass an NCD policy into law, which itself impacts the ability of the same or other stakeholders to implement said policies, and itself influence the ability to monitor progress and evaluate policy impact as necessary correct course. So the red points as well in the causal loop diagram mark the specific variables that we believe constitute barriers to implementation. Next slide. Here, it's a summary of the main barriers and facilitators that emerged from the review. I won't have time to go through all of them, and I will specifically more focus and mention some related to diet, because I'm also in the next slide going to show about the causal loop diagram that we revised based on the initial program theory and specifically based on the diet-related best buys. So for instance, just to mention some of the barriers that we identified for diet, some of the contextual barriers to the adoption and implementation of diet-related best buys related predominantly to macroeconomic forces. And specifically, government might be constraints in their ability to regulate and restrict the food market by the stipulation of international trade agreements. And as well as government's own ideological leanings, specifically neoliberalist ideologies, might also compromise the public sector's willingness to adopt this type of best buys. On the other side, conditions that are in favor of adoption implementations were noted as governments using, for instance, exemptions to trade agreements, such as favoring local government and the local procurements of local produce, and to try to influence the availability of goods in the markets. The next slide. And in this case, as I mentioned, so we revised, basically we went back to the original program theory and we revised it specifically for the diet-related best buys. And in purple, you can see the barriers that we identify as being more specific for diet, and in green, the ones that are more specific for the facilitators. Next slide. In here, I'm just giving an example because I'm aware that the previous slide was not very visible, but we wanted also to just give an idea of the complexity, the complexity of and the system dynamics. So in this case, just to give an example of some of the barriers that influence adoption and implementations for diet, and this is specifically related to the capacity. So for instance, resource allocations to the support implementation impacts directly the capacity for the implementation, as well as the capacity of the country of knowing what strategies for the implementation or how to navigate the trade challenges that I mentioned before. Another challenge can be the capacity to develop tools and resources, including the labeling of food packaging that does not require high literacy levels and high levels of agencies by the population. All these influence, as I said, the capacity for implementations and monitoring of the policy, and itself influence the availability of policy implementation plans and monitoring framework with the measurable indicators and impact assessment. Next slide. Here again, this is an extract from the causal loop diagram. In green, highlighted the facilitators to implementation, such, for instance, the evidence availability and specificity. Locally produced evidence emerge as a key facilitator for implementation, as well as framing the problem as a human right, and the role of, for instance, international agencies such as the World Bank, the United Nations, and WHO, and also the accountability to global targets and indicators, as well as the accountability to the own population. Next slide. Just to conclude then, we believe that complex theory methods can be very useful to support implementation research, and changing health systems orientation often requires a political struggle. So technical evidence is usually useful and frequently necessary, but the evidence alone rarely produce sufficient system change. This is why political economy factors and analysis are key to understand the barriers and facilitators to NCD. Action on NCD requires strong political commitment, tackling the commercial determinants of health and addressing the broad structural factors that shape political decisions. Also, governments need to take into account and develop clear guidelines on conflict of interest, and industry interference need to be addressed more sensibly. Monitoring systems to assess implementation progress are needed, national and global levels, and adaptation also to local context, as I mentioned before, is absolutely essential. And NCD policies in general need to be part of comprehensive whole of society approaches. I conclude here. Thank you so much.
Great, thank you very much, Giulia. So I hope you can see that we're sort of tackling these issues from lots of different angles. So we've heard about the kind of supply side system strengthening. We've heard a bit about the patient experience, access and utilization, and Giulia's been focusing more on the sort of macro policy, social determinants question. So all of these are key parts of the NCD jigsaw. So we're going to be moving next, as I said, to a more preventive but community level approach of social mobilization. So I'm delighted to welcome Peter Conteh and Dr. Kiran Cheedella from our Sierra Leone work. So Peter is a local researcher who works for the College of Medicine and Allied Health Sciences in Bombali district in Sierra Leone, and he is a social mobilization officer for the research unit on health and fragility. So his background is in development economics and community development, and he's worked since 2005 supporting project implementation, research, monitoring and evaluation for a number of different non-governmental organizations. Dr. Kiran Cheedella is a GP who worked with voluntary services overseas and the Royal College of GPs in Sierra Leone to develop and implement NCD interventions, working in collaboration with the Ministry of Health and Sanitation and also with our research unit on health and fragility. So he's now working as a salaried GP in Bristol. I think he's just dipped out of his clinics to join us today. So thank you very much, Kiran. And he's working with us on ongoing work on NCDs and also COVID-19 in Sierra Leone. So we've got another double trouble panel. Over to, I think, Peter is kicking us off. So over to you, Peter. But I think you need to unmute, Peter.
Yes, thanks very much, Sophie, for the introduction. I'm Peter, and I'll be presenting with my colleague Kiran. I will start and he will do the end. And basically, this story started last year in 2020, and as we all can see the study aim, it's just like a pilot project that aims to see how we can pilot test the social mobilization and intervention with key focus on high salt intake to prevent hypertension in the district. And there are two specific objectives in the whole pilot project. And the first objective, we want to see how we can develop the community-based social mobilization intervention materials with the key focus on preventing hypertension. And secondly, to see how best we can pilot test the intervention itself within these two communities. And we targeted two chiefdoms. One is a control and one is the intervention. The reason why we targeted these two particular chiefdoms, we want at the end of the day to compare our impact, where we've intervened and where we've not intervened. What will be the information? So we gathered a baseline survey and an endline survey to see at the end of the day if what we gather from the intervention and also what we gather from the control, where we've not done anything so far, if it is the same, then that means there is no impact. There is no use for the project, the pilot. But if there are discrepancies, there is more information gathered from the intervention, that we know that our pilot project makes a lot of sense. So I'm sure that is exactly what we did, and the analysis is still ongoing. So can we go to the next slide? Yeah. This is the background, and this statistics is in the protocol which we did. From these statistics you've seen is from WHO 2009 report that hypertension in Sierra Leone is 29.4% of men and 31% of women. So that means the risk of than men. And you will see some diagrams at the side. You will see this one is salt, and these other ones, they are different components of Maggi's. They are locally prepared. Some of them, all of them almost are prepared in Africa, and they have a lot of sodium chloride content in them. So despite the intervention is on salt reduction, but you see we captured something on this Maggi because of the sodium chloride content in them. And people are now subsidizing or substituting the salt instead of this Maggi because it also has some sodium chloride content in them, which is salt. So they rather use now this Maggi instead of the ordinary salt, which is the white content you have seen up. Yeah. And we also noted that some families, they are still using the salt, and they also use the Maggi when they are cooking. Yeah, so at the end of the day, they put a lot of salt and also the Maggi at the same time. But in as much as we are focusing on the discussion around lifestyle management, behavior change, because we want to see how our message will create an impact so that we'll see how they can reduce, because from our own content, we are not saying stop eating it automatically, because they will not accept the message. So the first stage, we are saying reduce the content you used to put. So if you used to put, because this you will see in different cubes. So if you used to put like 4 or 5 cubes, so now we say, okay, reduce to 1 or 2, so that by so doing, we also get their mind to support the process rather than them frustrating the process, because we know that there are a lot of people that believe in them, and if we can get them on board, they also have people that they can also pass on the message to, because the objective is for the people to take over the social mobilization process we are doing, and they take it as their own. So even if when we phase out, they will still continue with it. But if we just take it as our own project and they are not involved, they will not buy into the idea, and at the end of the day, we are losing a lot. So that is why we allow them to take ownership of the project, because we want to build onto the existing structures. Yeah, because a lot of structures we are on board, so we want to build onto those structures. RUHF has done a great job in building existing structures on the NCDs, and there are other a lot of structures they put in place so far. So we want to see how these structures can remain even when we are not working there. So that is why I want them to take ownership of the entire project. So this is how we can allow them, by involving them, to understand the project, that this project is not to condemn what we have been doing, but also to give us an eye-opener of the dangers of our practice, our lifestyle, and to see how we can own the process and change. Let's go to the next slide. Yeah. So this is just one of the activities we carried. And from this slide, you'll see the intervention and the control, because we intervene in 2 different communities, which is Mafari and Binkolo, and we also got 2 different communities as a control, which is Masumbo and Makari. So what we did was to select people within these communities for the intervention, structures which have existed before, like the Village Development Committee and the Facility Management Committee. So we selected the 20 we need from those structures that have existed before, but they are no longer like proactive as they're supposed to be. So we try to activate those structures and see how we can make them more robust and active to carry out our interventions. So we got the control communities and we got the intervention communities. So this is just one of the activities we held at the intervention community. Let's go next slide. Yeah, and this is the context. So the 2 villages that we intervene is just 1 mile apart, because we don't want to take a village here and that will get more difficulty to bring them together, because these structures, they were created to see how they can support, they can be like an intermediary between the facility and their communities. So these are stakeholders, they thought they are very crucial in terms of supporting the health facility within their communities. So we selected those communities that are closer, and we see how those structures that have existed before, that we can bring them together to support our social mobilization campaign. So the intervention villages, there are 2, Binkolo and Mafari, as I said earlier, to know the research team. Then we see how also the CHO himself is involved as part of the people who selected the people who should be part of the committee, because it's a 20-member committee of stakeholders that we thought they have stake really into not just in supporting the facility, but also their key stakeholders within their community. And we normally call them their opinion leaders, because when they speak, the people listen to them within their catchment. So we also bring them on board. And that's also what happened in the control. We also selected people for the baseline survey, people who think that they have stake into their society, not just everybody in society. People who think they have stake either because of their business, either because of their position in society, so that when we say something, there are other people who take it and cascade it further, not just like we bring a message and at the end of the day, where we end with the message, that's where it ends. No, but we want people, when we say something, with or without we being there, they will also cascade the message further. So that's what we did. And we also look at people who are relevant, as I said, people who are relevant, like the CHO is someone who is relevant in that community in particular. They normally call him the doctor because he's the only medical practitioner in that community. So he's the doctor they knows there. So we allow him also to be part of the process and support the whole initiation of the project within those communities. Let's go. Yeah. So this is how we get onto the stakeholders. First of all, we engage the stakeholders, myself and the CHO, who is the community health worker there, the community health officer. We engage the different stakeholders. We look at the existing structures and we see how can we reactivate it so that we can enable them to work based on our project, based on the intervention we want to do. So he also guided the process that this structure and this structure is in existence, even though there are challenges for them coming together. But if you actually use them, they will carry out the social mobilization better. So the first thing we did was to get their contact numbers, call them on a meeting. We sit down and we explain the entire project to them. And the second step is to look at those who are interested, who are really interested, and those who are motivated about the project. So there are two other people that were added who are not part of the VDCs and the FMCs. And the reason why we added them into the cluster is because they have a stake also based on the activities that we want to do. The school-going pupils, we add one female and one male into the number that makes them 20, because the ones we selected from the VDCs and the FMCs, they are 18 in number. But because of the stake, because we know that there are activities that we want to carry in the schools, and we need school-going pupils who can stand in front of their colleagues and speak, and with or without we being there, with the structures we want to establish, like the school clubs, those pupils will be the ambassadors to drive the school clubs. So we incorporated them into the group so that they will be the pioneers within those schools. So this, we said 4 meetings, but they were actually 4 workshops, but they were actually meetings, because these are gatherings where we get from them and they also get from us, and we share ideas, we develop materials together where they think that this will not work based on the context in which we operate. We also review. So that is why we call them meetings, because it's a learning point where they learn from us and we also learn from them. So the first one we held was to identify the stakeholders that we want to work with, to talk about the issue of hypertension, stroke, and COVID planning, on how we can beat it together as a country. And the second one is to produce the social mobilization material. And these social mobilization materials, we produce them together. And even if you go to the next slide, before we go to the next slide, you'll see the jingle. The jingle, it was produced in their local language, Creole and Limba, and they selected the words they want to see based on the pilot project. They also give huge support into that, because the first thing they advise us, if you develop a jingle in English, not much of our people can understand English. If you develop it in Creole, not much of our people can understand Creole. But if you do it in a local language, in Limba, they can understand it better. based on the context you want to pass on your message. So that's how we did the jingle. Even the radio discussion programs, we did those radio discussion programs in Limba and Creole, because there are also other people who cannot understand Limba. So we try to see the common language and also the intervention area, the most common language they speak. So we also identify key things that we need to put in place to support the social mobilization work. And when we are identifying the tools, they told us that one of the things that will make sense if you develop posters and stickers. So we asked them, why do you think that posters and stickers? They said, even for those community people who cannot read, but their kids can come for holidays, they will read these posters, they will understand. Those stickers and posters, they are not just for us, but for other people, even passerbys can read and understand. So we thought it's a brilliant idea for the stickers and the posters, because they are also tools they use for the door-to-door sensitization. The door-to-door sensitization, those who cannot capture during the community meetings, community awareness raising meetings, we can capture them during the door-to-door sensitization, because there are a lot of activities. We have the awareness raising meeting, we have the school sensitization outreach, we have the blood screening, wherein we do hypertension and screening. So we can tell you that your pressure is high, you need to control your diet, this and this is what you should eat, and this and this is not, this and this is not what you should not eat. So, and based on that background, we are able to like distinguish clearly how our intervention is going and the kind of support we need from the stakeholders. And Sophie and the team, honestly, this is one of the projects, this is one of the research I've been involved in, that community people there, we are so passionate to see how they themselves can contribute into the success of the project. Because when we did the screening, we found out that even part of the 20 stakeholders we engage, that they themselves should carry out the awareness raising meeting. Because for us, we did the trainings, the 4 trainings for them, and they developed the awareness raising meetings for themselves, the school outreach for themselves, the door-to-door sensitization during the periodic markets, during Sundays and so forth. They developed those activities for themselves, that these are the activities we want to carry. So you train us, give us the support, give us the tool, and we'll go out there. We have our megaphones, we'll go out there and carry out the sensitization. So for me, I look at this entire pilot project as something that the community people themselves, we are able to understand the whole context. Because when we did the screening, we found out that most of the members of the 20 that we targeted as a pilot, that we trained, most of them, they are hypertensive. But some of them will not go for blood for hypertension check, because they one, they don't have the awareness, and 2, they don't see it as if it is a problem. They can only know that I'm hypertensive when it results to stroke, and that's the time now they said it is witchcraft and so forth. So I want to pause there and invite my colleague Kiran to take on the next 3 slides.
Thank you. Thanks. And I know we're running a bit short of time, probably over time, so I'll be really quick. So there was quite a lot that came out in the focus group discussions. They were overwhelmingly positive. So people really noted in their communities less sickness in general. They noted that there was significant lifestyle changes within their community members, within themselves, noticing the street sellers had even themselves stopped putting as much salt in their food when they're selling it, noting when they go to functions that people are putting less salt in their food. People overwhelmingly felt that they had a better knowledge about salt and how to improve their lifestyle and hypertension and the links to stroke, such that actually local businesses were unable to sell their salt apparently, and had to reduce the prices. Motivations were generally people wanted to be healthy, which motivated them to change their lifestyle. Next slide, please. So with the stakeholder interviews, again, they echoed a lot of what the community members were saying with respect to the lifestyle changes that they were noting in the community. They really enjoyed working together. As I think Peter's mentioned, it was a very participatory approach. So they were involved at all the stages, involved in deciding what the activities were. So I think that was part of the success. And they did note that you know, having as stakeholders, their ability as people of, for example, religious people, priests, and people who were quite high level in the community, people generally listened to them, and they were able to pass on the message quite easily. And the next slide, please. So this is really the final slide. It's really just looking at what were the important ingredients were. And if we look back at this COM-B behavior change model, you know, they had the capability with all the knowledge that was given to them, you know, using the local language, discussing the root causes in their own language. The opportunities were there through providing them with resources, so giving them the T-shirts, stickers, and the things that they could do to try and push forward the message. Then providing them the motivation to change their behavior, which then fed back into the community, creating these opportunities for them with less salty foods in their communities, and improving their knowledge. People were talking about it a lot more in their communities, again, improving the motivation to change their lifestyle to try and have a healthier community. So that's it. Thank you very much.
Sophie, you're on mute. Sophie, you're on mute.
Okay, there we go. Thank you very much to the speakers, and thanks to Alistair for pointing out that I'm talking to myself in a room here. Yeah, thanks for rushing ahead with the time a bit, Kiran, and apologies for squeezing you at the end, but I'd like to hand over the floor now to Dr. Shao from WHO. So Dr. Shao supports the development of national policies, plans and strategies for the prevention and control of NCDs, for integrated NCD prevention and control and related research and capacity building. So he's the perfect person to just give some reflections on these four diverse but connected, I think, sets of work. So Dr. Shao, over to you.
Thank you very much, Sophie. And first of all, I would like to thank the organizer inviting me to join this webinar, which showed me very, very good results. I'm very, very happy to know all of these very good high-level research projects. And let me start from last one, because you're talking about the last one is about salt reduction and the community-based intervention, which gave me a lot of very good message. Particularly, I'm very interested knowing that how you tailor the interventions in context of local people, which is a very, very strategic tactic, strategic measures. So one quick question regarding salt reduction from your reports, which indicate the majority salt intake is from cooking food. So I understood the ladies, women is people who are making food. Is there any specific interventions targeting the women housewife who are making food? And no, I know you have a workshop, you have a video. Yes.
Oh, sorry. I can answer that. So specifically with the women, what they did was they talked to the women actually and the community members and asked them, what are the barriers? What are stopping you from being able to cook with less salt? And what they found was actually the men were actually quite obstructive to them not cooking salt, or they would maybe go to the other wife and eat their food. So what they did to try and target that was through the radio discussions and radio jingles, trying to encourage men to support their wives to actually reduce the amount of salt that they're putting in their food.
Yeah, exactly. That's I didn't finish. From experience from other countries, is exactly, you are right. It's not the women don't want to reduce, but it's my request. It's otherwise the man refuse the food or other problem fighting between the wife and husband. So that's thank you if you recognize, okay, it's good. And come back to the third regarding the is the implementation research project. I'm very glad to hear the report of systematic review using the standardized systematic review methodology. And one very small question regarding what the program theories is very complicated, very complicated. It's so what I understood is from implementation research series is what you report is a very generic general. And from implementation research, more look at local barriers and challenges, because those barriers challenges are very, not very general, is very well recognized. And from the implementation research, normally we very look at the context of the settings, countries. So you provide a very general pictures regarding various challenges implementing the best buy. But that will be very useful for other program projects if they are going to implement the best buy in countries where you provide a very good picture. So very useful. So congratulations. The component two second is I'm very happy to know you provide a number of very good interventions. We also showed the good result. Congratulations. And come to the first one, I was a little not very clear regarding what the interventions you have implemented in the field. Compared with the second one, which is I got a very clear message regarding lifestyle changes, the diagnostic testing, the referral to specialists. So those interventions are very clear, indicated. But the first one was not very clear. And also regarding screening, what's the methodology you used for screening, and then what's the coverage of your screening, and what's intervention I mentioned. But the problem is time is very limited. You didn't have time to give the full story. But anyhow, I'm very happy to be invited to hear, and congratulations, very good results. Over, thank you.
Great. So I don't know, do you want to take that last question, John? Because I think that was the main question there.
Yeah, sure. The package that we developed in various countries, Pakistan, as I mentioned, across the whole of the Punjab, with 750,000 patients diagnosed and treated already, and in other countries, and now with Nigeria and Sierra Leone through this project, we've adapted a package which includes all of those things for nurses, medical officers working in a health center, or people walking into a district hospital emergency room. So anybody walk-in patients, they are screened for the blood pressure. If they're overweight, they're also screened for diabetes. And they will also be checked and double-checked for those measures by the nurse in the consultation room. If they present with symptoms suggestive of depression, then the nurse goes to the depression page and will ask the various questions like the PHQ-9 type questions, as in the WHO guidelines for depression or for anxiety. And similarly, if they present saying they've had a seizure. So any of the presenting problems will be followed up according to the page on the NCD guideline, which is now adopted by the Ministry of Health, Nigeria and Sierra Leone. So the package is a broad package which includes screening as well as diagnosis and follow-up care, systematically following up using a treatment card and the call them if the patient doesn't come. So in other words, retrieval of late attending patients. And Akan presented the results after 3 follow-up visits with significant change in the BP, systolic and diastolic blood pressure, and other qualitative measures. Over.
Thank you very much. Do you want to come back on that, Dr. Shao? If not, I'll just put some general questions to the panel to wrap up.
Sorry, one more question regarding the last one question regarding package. So I'm wondering, John, would you recognize there are 2 packages published, WHO recommend? One is the PAN package, second one is the HEARTS. Both are package of NCD interventions.
Yes.
So I didn't see probably if there any possibility to use that as a reference or tailored that package to local settings. Because currently WHO is a very concerned integrated approach using such package. Over, thank you.
Yes, exactly. So we started with the WHO PEN package, and that various, over the years, additional material became available from WHO. So we worked with that package and tailored it to the local country context, working with the technical working group of the Ministry of Health in each country, most recently in Nigeria, Sierra Leone. So adapting from all guidelines and tools which were developed based on the WHO PEN. So as WHO requests, we should adapt to the country context. And importantly, there should be very user-friendly, very easy to pick up which questions to ask, what to do, and synthesized, made very concise, and then skill-based training to deliver that. And in Nigeria, we tested with good results doing that online. Over.
Great, thank you. Over for me.
Great, thank you very much. So there've been some questions and answers already addressed through the chat function. So I'm not going to pick those up again because I think those have been answered already by the panel. But I guess just one of the themes that's coming out in relation to the social mobilization and kind of community preventive approaches is really around how do you scale up? So it seems to work very well in this area where we've been working, and Kiran and Peter were very persuasive about that. But I guess how do we broaden it to other areas? So any thoughts from either of you on that question?
Yes, thank you very much, Sophie. I think the issue of scaling up, we discussed about that one yesterday, myself and Kiran as well. We've already established the structure, the social mobilization structure, that we think they have the capacity now, if they have been supported, to also cascade in other districts and other parts in Sierra Leone. And for every intervention, there are learnings, there are lessons learned. So one of the lessons we've learned already, one of it is that if we involve the community people from the start of the project to the end of the project, you find out that they will own the entire process. Everything about it, they will take it as their own, because it's not like you initiating the project and you own everything. We gave them the opportunity to participate, to make their contribution, and their contributions have been heard. And now if we ask them, and that is why also during the intervention, we ask them to develop activities that they think they can carry out successfully. So they develop those activities. So they thought that one of the successful strategy they will carry, despite with or without fund, is the door-to-door sensitization. They find it very easy that not everyone you can gather in a town hall meeting. Some of those people, you meet them not official period, maybe when they are cooking, you talk to them about salt reduction, because those are the sustainable strategies. Not every day you go to the radio, not every day you get a jingle aired out. But those community activities they do, those one-to-one visit they do, they also create an impact. Someone is just asking me on the chat, what are the structures? We already have a social mobilization structure. We already have a screening structure headed by the CHO. he is also training his own health workers that for every patient that is coming to the facility, they must screen them for high blood pressure. So that's one of the structures we've already established. And what we did also to establish a linkage between the community and the facility, because that was something that was not being done before. People are not coming out for high blood pressure check. But now, because of the awareness, they are coming out. So all that we want to see is for us to create the awareness so that people can come to the facility and they are being screened. And also when the facility are moving for their outreach, because the health facilities are also moving for outreaches, monthly outreaches. So they also carry out the screening when they are going for those outreaches. And for those patients that they think they can refer for them to come to the facility, they can refer them as well. So I think those are the structure.
Thank you very much.
Yeah.
Sorry, Peter, I'm just aware we're very short of time. I just want to make sure we put a couple of questions to the other members of the panel. I mean, I think just turning to Shadi, the issue, obviously your presentation focused very much on the sort of inequities across different population groups. And I guess it would be interesting just to hear from your reflections on what are the most important policy actions to reduce these inequities in access to NCD services in Lebanon.
Thanks, Sophie. I have to sign off in a couple of minutes, so it's good time.
Incentive to be brief then.
good timing with the question. I think that the main thing is because most of what we're seeing is happening, or at least the stuff that we explored is at the level of primary healthcare. And I think that there's a strong primary healthcare department at the Ministry of Public Health that oversees that process. So this is when it comes to the issue of nationality and coverage. Now, I always say that there's a larger context when it comes to the gender dynamics. Obviously, this is something that is even larger than the healthcare system itself. It has to do with societal norms and so on and so forth. So definitely issue of awareness, of outreach is relevant and important.
Okay, great. Thank you very much, Shadi. I also just wanted to follow up with Giulia on this issue of political economy thinking. Really interesting. And I guess I'm just interested in how it can be incorporated in how we implement NCD policy. Have you come across any good examples or good practices in that area?
Thanks for the question. Yeah, I think, for instance, I think just a couple of examples that I can think of are, one is around the sin taxes, so the taxes that are implemented as suggested for instance, alcohol, tobacco, salt, or sugar. And so obviously when government trying to implement these sin taxes, this trigger inevitably a political struggle with the commercial organizations. And industries, for instance, have a much greater economic and political resources than public health advocates. So understanding when and how public health can win despite the powerful forces requires eventually a political economy analysis. So for instance, just an example is how this can look like in practice. And during the Global Health Festival that we organized, we screen a movie which is called El Susto, which focuses specifically on the successful passage of the soda tax in Mexico. So in examining this topic, colleagues and activists and researchers showed how advocates can achieve the legislative success with this political difficult proposal and using exactly a political economy analysis, and to decide the strategies to promote the tax in Mexican society and push the tax through the Mexican Congress. Another quick example and linked to the social mobilizations can be the world experiences with HIV and AIDS and the critical role played by the affected people in organizing social movements. So social movements of people living with HIV or AIDS have played a catalytic role in changing government roles, regulatory policies, healthcare delivery. So studying all these forces and processes can definitely is very critical when we try to implement policies.
So thank you, Giulia. I mean, we could run and run on these, and I think we're going to have more webinars, but just to say we're out of time. Thank you so much for all those really rich presentations and for answering the questions. And I think there's a lot of interest and enthusiasm, so we need to follow up. And just to say there's another 2 webinars tomorrow that we're running, one on mental health in the morning and one focusing on responses to COVID in the afternoon. So do join us for these next 2 webinars if you can. Thanks for joining today, and we will continue the work. Thank you, colleagues.
Thank you. Bye.
Thank you.
Bye-bye, everyone.
Bye-bye.
Thank you. Bye-bye. Bye-bye.